scapular dyskinesis. This is interesting. Okay, so this is where you have the abnormal patterns with the scapula whenever they're doing them, going through the motions. You can see this in a lot of overuse athletes that, such as swimmers, tennis, baseball, any kind of throwing overhead athletes. And that has a lot to do with the muscle imbalances between each shoulder. So the one that you're throwing more with, you're going to have looser muscles depending on which motions you're doing. Talk about that. Okay, so you have the trapezius and the lower trapezius and then the serratus inferior all acting on that, on the scapula. So whenever you're going through a motion and depending on your mechanics, you can either be stressing too much on one muscle or not enough on another, and that'll cause an imbalance in the scapula. Some things. Okay, so here's a baseball picture. You can see this is kind of what I want you guys to be starting to think about for once we start getting into what is it, like anterior capsule problems and stuff. But so like some of the risk factors, like I talked about, overhead throwing athletes, that's the main way that you're going to see this in. And signs and symptoms, the scapula is going to appear dropped or drooping, and also heard of scapular winging as well. And there'll be also a limited range of motion depending on which one too. Okay, subacromial impingement. So you got your bursa. We talked about bursitis a little bit. So you have your subacromial bursa in your shoulder too, and that can be swollen. That can become inflamed as well, and that's going to cause pain with any motions. The big indicator about the bursitis is that they're going to have, okay, first of all, there's two types of impingement. You can have rotator cuff impingement or rotator cuff tendonitis, and that's where those tendons, as they come underneath here, they'll become inflamed, and then you can also have where your bursa will become inflamed too. So, and the only way to really diagnose that is to get an MRI, but with the swollen bursa, one of the big indicators is that when you get, they won't be too pain-free until they get to about 90, and then once they get to 90, that's when your shoulder, like everything kind of just mushes together, and if you have an inflamed bursa or inflamed tendons, that's going to cause pain just because you're enclosing that space even more. Okay, so some of the symptoms that they'll present with is a gradual onset of pain. Big indicator for bursitis is pain when sleeping at night, and then obviously doing activity that's going to re-aggravate it too. So that's it. Up in the top left are examples of just that enclosing of the space would be the acromion and the glenoid. And then here here you can see, like I was talking about, when they're at neutral position, and then once they get to 90, they get that impingement, quote unquote. But the thing about impingement is that you gotta realize it's always stemming from something else. So depending on their mechanics, depending on what they're doing in the weight room, it's not just one of those injuries that you can get from like a direct blow or an acute. It's usually just due to a biomechanics issue. So if they're, I mean, you can have impingement as a result of rotator cuff tear also. So that can be referring to that because they're using a different muscle rather than what they should be having their rotator cuff firing. Or okay, so these are some of the shoulder exercises that we like to do for any kind of shoulder injury. So AC joint sprains, dislocations, any kind of impingement that we think is going on. And so you want to do, also rotator cuff tears too. So if you show it. Okay, so the way you're going to instruct the athlete, so you get them to do internal rotation, elbow always at the side, okay, and then also turn it around and then do external rotation like this, and then extension, and then flexion as well. And the key point that we always talk about is that you don't want them to go above 45 because once you get right at 45, you're starting to train the deltoids and tricep and bicep. And what we're trying to do with these exercises is train the rotator cuff muscles that are specifically stabilizing the joint. And that's, you'll see with a lot of issues, is that sometimes these athletes, they don't have that firing of the rotator cuffs, which is causing the deltoids to overcompensate for it. And then, so you also have like abduction too. So we will only tell them to get to about like right there, usually. I mean, if it hurts them, then just go like down to 20, and then just build up from there.
So can you demonstrate 45? Or like, what do you mean?
Oh, like 45 degrees right there.
Yeah, but with the other ones too.
Oh, with the other ones,
Yeah.
just going like this,
Oh.
like all the way.
Oh, okay.
And then not necessarily getting like all the way to that 90-90. And then same with external. If they aren't a throwing athlete, why do we need to put them in this position? Right? This is just my belief. So you get athletes who have a dislocation or have like anterior laxity or posterior laxity. Why put them in a position that's causing them to have even more laxity? I mean, you see people like tossing the baseball going like this, but if you think about it, that's just causing more stress on the anterior capsule. So that's why I like to do the internal and external rotation right here,